Hello, everybody. My name is Amr Mohammed. I am pediatric ophthalmologist from Yemen. I would like to talk about my FRCS Glasgow Part 3 exam experience. So first of all, I appeared for the exam on 23rd April and 25th April 2024 at Amman, Jordan. And I passed from the first attempt, alhamdulillah. I cleared ICU Basic in 2014 and ICU Clinical in 2015, ICU Advanced in 2019. The biggest challenge for me was that I am away from general ophthalmology since 2019. My practice is focused on pediatric ophthalmology, strabismus, and adult cataract. So, first of all, you need to set your study plan and stick to it. So you need to sit with yourself, gather all the study sources, and decide how much time you need to finish everything. And you need also to add extra time for emergencies. After planning, start execution and tailor the plan accordingly. You need vacation before the exam, especially if you have tight schedule, because most of us who are taking this exam are already working ophthalmologists. So most of us have a tight schedule with a lot of operations and clinics. So it's worth it to sacrifice part of your annual leave to pass the exam from the first attempt. For me, I did 5 weeks of studying while working, average 6 hours daily of studying, then 3 weeks of vacation, average 12 hours daily of studying. And always remember, the harder you work, the luckier you get. So try to study hard, do your homework, so you will pass from the first time, inshallah. So regarding the study sources, for me, first thing was Kansky 8th edition, and it's really helpful. And I know many of us will be skeptical about studying Kansky for the exam because it's very lengthy and it's very thorough, but it's really important, and every word in Kansky is important, and it's worth reading it 2 times or 3 times before the exam. It's really important. It is one of the most valuable sources for this exam. Second source, Practical Guide to Viva and Oskin Ophthalmology Examination by Wong. It's very important book. It has the same style for the Viva examination. So, and it has covered most of the most important cases in each subspecialty. So it's really worth it to read it 2 or 3 times and test yourself in the cases in this book. Thirdly, Internal Medicine Notes by Dr. Walid Badr. It's around 100 pages and it's really very, very helpful. Other resources like Oxford Emergency Medicine also can be used. Previous exam experiences, especially the most recent exam experiences, is the most valuable source of studying. You need to study previous exam experiences and answer the questions you will find. You'll find a pattern and favorite questions that will come frequently and will come again and again in every exam experience you will read. Stick to those favorite questions, and 80% of the exam mostly will come from it. So many questions are very important, like diabetic retinopathy. Definitely you will get a case of diabetic retinopathy, whether in the Viva or in the clinical, or maybe in both. For example, glaucoma questions like post-trabeculectomy, whether low IOP or high IOP, management of medical management of primary angle glaucoma, primary open angle glaucoma, and also neovascular glaucoma and other types of glaucoma. Those are very common questions. In addition to that, anisocoria, Horner syndrome, pharmacological test of the Horner syndrome, RAPD, definitely you will get a case. What are the causes of RAPD? As I mentioned, there are many repeated questions. Try to study those questions very well and many of the questions that will come to you will be repeated from the previous exam experiences. Also, having study partner is very important. 1 hour of daily practice with a study partner will be very helpful. For me, I did that practice with one of my colleagues. So we did that daily for almost 2 months before the exam. So that was almost 60 hours of studying together. So each one will prepare 3 questions from the past candidate experience with the answers, and will ask each other. And after asking, he will tell me what are the mistakes, what went wrong, what went right. So you will know where are the weak points you have and what are the mistakes you have done, so you will not repeat those mistakes in the exam. Clinical examination videos like Dr. Ayman Al-Ghanimi, Dr. Muhammad Al-Naggar, you will find many valuable resources for clinical examination YouTube. Try to check those and practice clinical examination in your clinic many times before the exam. Dr. Ghada Zain Al-Abidin channel has a lot of valuable resources as well. And also on YouTube, you will find a lot of exam experiences. Just write FRCS Glasgow Ophthalmology exam experience, and you will get many valuable exam experiences. Dr. Chua's book, Clinical Examination Techniques, and Mutosami University Group. For me, Viva examination was on 23rd April. So reporting time was 1 p.m. We waited in the candidates waiting area. Exam started around 3 p.m., finished at 4:10. For me, the sequence was first table neuro, second table anterior segment oculoplasty, and third table posterior segment and glaucoma. And every candidate will have different sequence. So it depends on your candidate number. And actually, it's okay. Whether table you will start with, anyway, you will go through the 3 stations. So don't panic. If you get a tough table, then inshallah you will get other ones will be easier. Interval of 2 to 3 minutes between each station. So first table, it was neuromotility and general medicine. Scenario number 1, it was written scenario. And actually, I got a lot of written scenarios. And I think that was the pattern for many candidates who gave the exam recently. Many written scenarios are there in the exam. So first scenario was patient undergoing cataract surgery. And it was found that the patient is having atrial fibrillation. What are you going to do? So I mentioned we need to know whether it is acute or chronic atrial fibrillation. Then we need to give medications like beta blockers, digoxin. If no improvement, then patient might need cardioversion, whether it is electric or drug cardioversion, and also anticoagulant drugs. He asked what are other drugs for anticoagulation and what are the causes of atrial fibrillation. Scenario number 2, written scenario, patient who has cataract and plan to do cataract surgery, and patient is on warfarin. So what will you do for this patient? So I answered that we can do the surgery under topical or subtenual anesthesia to avoid the risk of retrobulbar hemorrhage from the local anesthetic injection. And we can do also clear corneal incision. I don't know if you want something else, but he did not comment at all. When I'm thinking now, I think one possible answer would be I would like to coordinate with the physician whether we can stop warfarin or give other anticoagulant before the surgery. Maybe that was the answer the examiner was looking for. Scenario number 3, female with galactorrhea and amenorrhea. So what is the most probable diagnosis? So I answered that the patient is having chiasmatic lesion, mostly pituitary adenoma. So the other question, what are you going to do? So I mentioned examination, anterior, posterior segment, check optic disc, check pupillary reaction, check confrontation, visual field, everything. Then also visual confrontation, visual field, and automated perimetry. In addition to that, neuroimaging like brain MRI, hormonal assay for prolactin and other pituitary hormones. He asked what is the expected visual field effect in this patient. I mentioned bitemporal hemianopia. What is the medical treatment that can be given? I mentioned bromocriptine or cabergoline. Then he mentioned other options. I said if the patient still is having complaints or there is progressive visual field loss, then we can proceed for surgery, transsphenoidal hypophysectomy, neurosurgical procedure. Other options he asked, I mentioned stereotactic radiotherapy, but I think he wanted something else. Then lastly, he asked, post-surgery, the patient developed polyuria. What is the problem? The next scenario was about patient with diplopia and ptosis, and all the questions were about myasthenia gravis in details. The clinical test, like sleep test, eyes test, fatigability test, the variability in the ptosis and the variability in limited ocular motility, lab investigations, and pharmacological tests, specifically tensulin test. He asked about everything related to tensulin test, the dosage, how would you administer the hydrophonium, and what are the precautions that you need to do while doing this test. Scenario number 5, a case of 5-year-old patient with vision 6.6 and 6.18. What are you going to do? So I answered again, thorough examination, anterior segment, posterior segment, cover test, extraocular motility, cycloplegic refraction. Examiner said everything is normal. Then I said it could be amblyopia. So he asked, what is amblyopia? What is the definition? What are the types of amblyopia? What are you going to do for this patient? Then I mentioned I would give classes if the patient is having any significant refractive error or anisometropia, and I will do amblyopia therapy. Then he asked the amblyopia therapy. I mentioned patching of the good eye. Then he asked other options. I mentioned penalization with atropine eye drops. 6 scenario, patient who is 3-year-old with acute onset of convergent strabismus for 1 month. So what are the differential diagnoses? So I mentioned acute esotropia, accommodative esotropia, and 6 cranial nerve palsy. So he asked, what are you going to do? I mentioned full examination, including cover test, extraocular motility to differentiate whether it is comitant or incomitant, pupillary reflexes, anterior and posterior segment, cycloplegic refraction. Then he asked, what is the most common cause in this age group? I mentioned accommodative esotropia. Then the next question was, what are you going to do for this patient? So I mentioned full cycloplegic hypermetropic refraction glasses and treat amblyopia if there is any fixation preference. The last scenario in this station was elderly patient with lateral rectus paralysis. So what are you going to do? So I mentioned I need to ask history about any systemic diseases, history of the onset, progression, duration, measuring the angle, and checking other cranial nerves, anterior, posterior segment examination, pupillary examination. Then he asked, what are the investigation would you do? I mentioned lab investigations like blood sugar, lipid profile, blood pressure, and also neuroimaging, especially in patients that is not improving within 3 months. Then how would you manage? Acutely, we can do patching of one of the eyes or prism glasses. Then the question was, if the patient came after 6 months with stable deviation, what would you do? So I mentioned we can proceed with strabismus surgery if the deviation is stable. Examiner asked what are the other options. I mentioned botulinum toxin, but usually it is not effective after 6 months of deviation because of the medial rectus muscle restriction. What else? I mentioned Fresnel prism. Table number 2, anterior segment and oculoplasty. So scenario number 1, it was written scenario. Patient who will do a cataract surgery under local anesthesia. What are the historical points that is important? So I mentioned systemic diseases. I would ask the patient about the onset of the loss of vision, progression, duration, any pain, any other complaints, any history of trauma. So I mentioned also examination, anterior segment, posterior segment, intraocular pressure, check the other eye. The examiner kept saying, what else, what else? So I think he wanted that table in Kansky that is mentioning all the systemic conditions that you need to ask about and you need to check before elective eye surgery. So it includes everything like suspected MI in the past, angina, respiratory disease, leg ulcer, skin wound, rheumatic fever, stroke, rheumatoid arthritis, jaundice, HIV, sickle status, Parkinson, epilepsy, myotonic dystrophy. A lot of things are there in this table, so maybe he wanted all these points to be mentioned. Scenario number 2, it was a picture of a child with left leukocoria. So I mentioned patient is having left leukocoria, and I mentioned all the differential diagnoses. Then the examiner asked, if this is a case of PHPV, what are you going to do? So I answered, it depends whether it is anterior or posterior PHPV. If it is anterior, then we can do cataract surgery with guarded visual prognosis. Then the examiner asked, what are you going to counsel the patient family about? I mentioned visual prognosis, need of amblyopia therapy postoperatively, risk of glaucoma, retinal detachment. Also, I mentioned the approach for a case of leukocoria, including the need for examination under anesthesia and B-scan ultrasonography to rule out any intraocular tumors and also to rule out retinal detachment. So the third scenario, it was a written scenario, and it was, how would you counsel a patient for a cataract surgery? So I mentioned that I need to tell the patient about all the possible complications like PCR, leaving the patient aphakic, risk of endophthalmitis, bullous keratopathy, glaucoma, persistent uveitis, risk of rupture globe, or retrobulbar hemorrhage from anesthesia. Then the next scenario, it was a picture of external photography of the of eye with the lower lid basal cell carcinoma. It was a rodent ulcer. So the examiner asked to describe and what is the most probable diagnosis and how would you treat. And he wanted everything regarding the lid reconstruction. If it is less than 1/3, if it is between 1/3 and 1/2 of the lid, if it is more than 1/2, how would you reconstruct each case? The fifth scenario, it was a slit lamp photo of anterior segment with rose bengal staining in the cornea. So he asked me to describe, then asked what are the other stains that can be used and what another test for dry eye. I mentioned tear breakup time, Shermer test 1 and 2, and tear meniscus height. Then he asked, how do you treat this patient? I mentioned if patient is having any systemic diseases related to the dry eye, like Sjogren's syndrome, we need to treat the underlying cause. Then we need to start with the environmental changes, lid hygiene, frequent blinking. Also, I talked about artificial tears. We can shift to also preservative-free artificial tears, topical steroids, the role of topical steroids and cyclosporin in such cases. In addition to that, punctal plugs, systemic treatment also that can be given like doxycycline for MGD. Then I mentioned also surgeries if the patient is having lid problems like entropion, tracheostomy, ectropion that can aggravate these conditions to treat dry eye. The sixth scenario, it was a patient, a partial photo of an elderly patient with lag of thalamus and mouth deviation. So the question was, what is the most probable diagnosis? So I said there is a lag of thalamus. Most probably there is a facial nerve palsy because there was also mouth deviation. So the next question was, what are you going to do? So I mentioned we need to refer the patient to neurologist. Then for the eye temporary measures, we can give lubricant eye drops, lubricant ointment, eyelid tapping. Then if it is permanent facial nerve palsy, then we can go for the permanent measures like medial cantoplasty, lateral tarsorrhaphy, gold weight implant. The examiner asked me, do you do these procedures by yourself? I mentioned no. Then also the examiner asked, what about botulinum toxin? I mentioned yes, we can use botulinum toxin. Then the examiner asked, in those patients, usually what they have, tearing or dryness. I mentioned tearing because of the punctal eversion and the reflex tearing. Then the examiner asked, if you are not doing those surgeries by yourself, what are you going to do? So the answer simply was to refer the patient to oculoplastic surgeon. The last scenario in this table was a case of child with lead swelling and redness for 2 days. What is the differential diagnosis? So I mentioned preseptal cellulitis, orbital cellulitis, and conjunctivitis. The next question was how to differentiate orbital from preseptal cellulitis. And if it is a case of orbital cellulitis, what are you going to do? So you need to study all the ocular emergencies in details like orbital cellulitis, retrobulbar hemorrhage, the traumas, acute angle closure glaucoma, retinal detachment, endophthalmitis, keratitis. All the ocular emergencies are very important and you need to know them by heart, and you need to answer all the questions related to ocular emergencies in the exam. The third table was posterior segment and glaucoma. So the first scenario was post-trap day 1, patient has shallow AC and IOP of 3 millimeter mercury. What are you going to do? So I mentioned I need to assess first the degree of AC shallowness, whether it is grade 1, grade 2, grade 3, and I need to check Seidel test to see whether it is positive or negative, and assess the bleb height. Differential diagnosis, it might be overfiltration, it might be bleb leak or ciliary shutdown. Then I said also I need to check the fundus. Then he said, could it be choroidal detachment? I answered yes, it could be choroidal detachment. Then he asked, what are you going to do? I mentioned bandage, contact lens, patching, decreasing steroid, increasing antibiotic eye drops. But it seems the examiner wants something else. The second scenario, again, post-trabeculectomy with a shallow EC and IOP of 70 millimeter mercury. So I mentioned we have 3 possibilities, whether pupillary block, suprachoroidal hemorrhage, or malignant glaucoma, and I mentioned how to differentiate between the 3 possibilities. The examiner mentioned it is malignant glaucoma. What are you going to do? So I mentioned we started with cycloplegic eye drops. I forgot anti-glaucoma eye drops. Then he mentioned what else? I mentioned if the patient is pseudophakic, we can do YAG laser, a posterior capsulotomy with hyaloidotomy. If the patient is phakic, then we can do YAG laser through the PI. If no improvement, then we can refer the patient to VR surgeon to do vitrectomy. The third scenario, patient with primary open angle glaucoma with IOP of 30 millimeter mercury. What are you going to give him? So the question simply was about the medical management of open angle glaucoma. So I mentioned the anti-glaucoma eye drops, and he asked, what are you going to tell the patient? I mentioned about the counseling for the patient, about the eye drops complications and the need to use the eye drops for life because it is progressive and chronic disease. And the examiner asked the patient is not comfortable, then I mentioned we can shift to another anti-glaucoma eye drops. The examiner mentioned patient is not tolerant to any anti-glaucoma eye drops. Then I mentioned laser trabeculoplasty. The examiner mentioned patient do not want laser. So I mentioned we can shift the patient on preservative-free anti-glaucoma eye drops. And it seems that was the answer that the examiner was looking for. Scenario number 4, it was a photo of a patient with central retinal artery occlusion with serioretinal artery sparing. And the question was, what are you going to do? So I mentioned if it is acute loss of vision less than 24 hours, then we can start with the emergency treatment like breathing in paper bag, carbogen, anti-glaucoma, ocular massage, paracentesis, checking the other eye, referring the patient to cardiologist or internist to do investigations like carotid Doppler ultrasound and echocardiogram, and the examiner stopped here. The fifth scenario, it was a case of vitreomacular traction. It was a OCT macula picture. So the questions were described, then what is the treatment? So I mentioned it depends on the vision and the visual symptoms. If the patient is having good vision and no metamorphopsia, then we can observe because sometimes it can improve spontaneously. If the vision is worsening or there is severe metamorphopsia, then we can do pars-plana vitrectomy with membrane removal and sometimes iron peeling. Sixth scenario, patient is having rheumatoid arthritis and taking systemic medications. What are the drugs that can affect the eye? So I mentioned steroids can cause posterior subcapsular cataract, glaucoma, increase the risk of corneal infections, also hydroxychloroquine. Then the examiner asked about everything about bullseye maculopathy, how to diagnose, how to screen the patient, how frequent would you screen the patient, how do you evaluate the patient in the clinic with visual field, with color vision test, and what is the toxic dose of hydroxychloroquine, what are the conditions that if the patient is having, the risk of toxicity will increase, and it was renal disease because the level of hydroxychloroquine in the body will be higher because of decreased metabolism of the drug. The last scenario in this station, it was a photo of glaucomatous optic disc. It was large disc with large vertical cupping with peripapillary atrophy, nasalization of the optic disc and bionetting. So the questions were everything about how to evaluate a patient with glaucoma, starting from the history examination, then investigations like central corneal thickness, OCT nerve fiber layer, visual field, everything in details. So coming to the second day, it was the clinical examination on 25th April. So the reporting time was 1 p.m. We waited again in the candidates waiting area. Exam started around 3:30 p.m. and finished at 4:30. The sequence for me was first station oculoplasty, second anterior segment, third posterior segment, and fourth neuro and strabismus, interval of 2 to 3 minutes between each station. First station oculoplasty, first question, 45-year-old female with bilateral dermatochalesis and ptosis. So the examiner just said examine without any specification. So I started by observation and I mentioned all the findings. Then he said, okay. I said, I want to examine for the ptosis. The examiner said, proceed. Then I did MRD and palpebral fissure height, levator function, lid crease. Then I told the examiner I want to check for the lag of thalamus Bell's phenomena, and I told also I need to check corneal sensation. Then I said I want to check for the cause of the ptosis. I need to check extraocular motility, pupils, and I need to check for fatigability test. Then the examiner asked, how would you do it? And what other tests that can be done? I mentioned eyes test and sleep test. Then he asked about myasthenia gravis, the investigations that can be done, and how would you treat a patient with myasthenia gravis. Second case, it was a patient with silicone stent post DCR. So the questions were about what are the indications for DCR and what are the complications of DCR. Third case, it was a young male with phthisis bulbi. So the examiner instructed me to examine the patient with torch, and I answered the patient is having phthisis bulbi, then the chronic endophthalmitis, post-intraocular surgery, severe trauma. The examiner asked, look again and check what is the cause in this patient. I checked again and I could not answer what is the specific cause for the case. I saw some skin markings or skin scarring, so I mentioned it might be a case of trauma, but I'm not sure. And my advice, do not waste your time. If you don't know the answer, you can just say, I don't know, or I can't recall. Then the examiner will move to the other questions and you will have the chance to answer more questions and you will have higher chance of passing. Then the other question, what are you going to do for him? So I mentioned for cosmesis, we can give colored contact lenses, prosthetic shell, or because of loss of the orbital volume, we can go for evisceration with orbital implant and prosthetic shell. The second station, anterior segment. So examine the left eye with the slit lamp. The patient had a clear cornea, 2 sutures, irregular pupil, slightly inferiorly subluxated scleral fixation IUL, and AC reaction +1. The examiner asked what could be happened to the patient. So I mentioned it might be traumatic cataract and there was no capsular support, or maybe patient was pseudophakic and IUL dislocated. Then second surgery done and scleral fixation IUL done for the patient. Or third scenario, it might be a primary aphakia and secondary IUL, scleral fixation IUL, because there was no capsular support. So the second question, what are the things that you need to examine? I mentioned intraocular pressure and fundus. Why intraocular pressure? I mentioned patient might have glaucoma from the main cause if it is a case of trauma, or also uveitic glaucoma because the patient is having AC reactions. Then the examiner asked regarding the IUL slight subluxation, what are you going to do? So I mentioned if the vision is good, then only conservatively we can manage the patient with the glasses. If the vision is poor, then patient might need contact lenses. The second case was elderly patient with bullous keratopathy, aphakic bullous keratopathy actually. He had a large superior corneal wound, maybe intracapsular or extracapsular cataract extraction, large part of iris lost superiorly, and bullous keratopathy with central epithelial defect. So the question was, what could happen to the patient? I said maybe intracapsular cataract extraction complicated, or extracapsular cataract extraction complicated without IUL implantation. Then examiner asked, what are you going to do for this patient? I mentioned I need to check the IOP and B scan. If it is normal, then we can proceed for graft for the patient. Examiner asked what type of graft. I mentioned whether penetrating keratoplasty or endothelial keratoplasty, depending on the level of stromal scarring for the patient. And what else? I said also patient will need IUL implantation, and I mentioned we can do a staged procedure for the patient, graft first, then IUL, or a combined procedure. And he asked about advantages of each procedure and what can be done if we did only graft for the patient. What are the medical options to correct the refractive error? So the answer was contact lens rather than doing second surgery. The third case, it was a case of a patient with endothelial keratoplasty and pseudophakia. And he asked, what do you think? Is this graft clear or not? And then time up. The last station, the third station, posterior segment. So the first case, examined with 90D lens. Patient has a full thickness macular hole, and all the surrounding area was pigmented, so it was not a very clear hole. So I mentioned full thickness macular hole. He asked about the grading of macular hole. What are the causes of macular hole? What is the surgery for macular hole? And what are the complications of gas injection? And what are the types of gases that can be used? What are the precautions that you will give the patient post-gas injection? I mentioned face down position and no air travel. The second case, examined with indirect ophthalmoscope. Patient had pale optic disc with regressed fibrovascular membrane in front of the disc, 360 laser marks. So I told the findings. Then the examiner asked what could be the cause. I told I want to check the other eye. Examiner said it has the same findings. Then I said it might be a case of stable proliferative diabetic retinopathy. Examiner said, okay. And he asked about what are the indications for vitrectomy in a diabetic patient, and also asked about the silicone, complications of silicone in a cases of vitrectomy, and for how long we should keep silicone in the eye, and also asked about PRP laser. How would you do PRP laser? The settings, the spot size, how many spots. Then asked about macular edema, how to manage macular edema, and if the patient is having macular edema with vitreomacular traction, then what can you do? I mentioned that injections are contraindicated in such cases. So maybe vitrectomy with the removal of membrane would improve the macular edema in such cases. Third case, examined with 90D, this child, it was 8 or 9-year-old boy. He told me spot diagnosis. The disc was really very strange. I did not reach the diagnosis. I told it may be congenital optic disc anomaly, might be a morning glory or optic disc glaucoma or glaucomatous optic disc, and time up. The last station, it was neuro and strabismus. So the first case, 15-year-old male with exotropia. The examiner told me to examine ocular motility. So I mentioned I want to examine cover test first. Then he told me, okay, do it. So I did cover test at near and at distance. And I asked the examiner that I want to measure the deviation. He said, okay. He gave me a prism bar, and I did the measurement for the deviation. It was 35 prism diopter exotropia. Then examiner asked me, do you want to measure deviation without glasses? I said yes, but the patient cannot see without glasses that target. So I just did Hirschberg test, and I told him almost the same angle. Then I checked motility. Patient had inferior oblique overaction in both eyes. And he asked about what are you going to do? I mentioned full examination and give glasses if the patient is having, like give the refractive error, the glasses for the refractive error, and treat amblyopia. If present, then I will proceed for strabismus surgery. Second case, it was a middle-aged woman. Examination of the pupils. So I mentioned I checked for heterochromia and anisocoria in light. Then I asked the examiner to switch off the light. I checked anisocoria in dark. Then I checked direct consensual light reflexes and swinging flashlight test. I noticed grade 1 RAPD in the left eye from the second attempt. Then the examiner asked what you want to do. I mentioned I need to check the fundus. He said, okay, check it. I checked. The patient had a cup disc and disc pallor. So I mentioned it might be glaucomatous optic neuropathy. The examiner told me to check the other eye. I checked other eye, disc was normal. Then he asked about what are the types of optic atrophy, and I think I could not reach the exact diagnosis for this patient, like what is the type of optic atrophy that patient was having. The third case, examiner asked me to perform confrontation visual field test for a third patient. I just started with the beginning of the visual field, then the bell rang and I could not complete the case. So my comments, there is a grading system to evaluate candidate performance. You don't need to answer everything to pass. I had some mistakes in some of the cases, and also some questions I could not answer properly. And that is the case with almost all the candidates who took the exam. So you don't need to answer every question to pass. There is a grading system. 1, 2, 3, that is fail out of 6. 4, 5, 6 out of 6 is pass. So you can get 4 out of 6 and you can pass. My single best advice is to keep calm during exam. It is a mind game, as many past candidates said. One of my colleagues advised me to forget that you are in an exam and take it as a discussion with a senior colleague. Thirdly, if you did not perform well in one station, keep fighting. You still have the chance to pass if you perform well in other stations. Practice clinical examination and master the techniques before the exam. Just keep repeating again and again to master it. Keep praying, prepare well, and you will pass. Definitely, examiners are helpful. Some examiners are not very helpful, but I believe the examination system is fair, and no one can fail you unless you perform poorly. Do a lot of oral and clinical simulated exams. That is the best way to be mentally and psychologically prepared. Sometimes you know a lot of information, but you don't know how to express it. Simulated exams with your study partners will help you a lot in practicing how to speak, how to elaborate things, and how to describe the photos, how to answer the questions. So it is very important to do a lot of simulated exams with your colleagues. Thank you so much.